Yeah. Perfect. Thank you. Okay. So the aspects I wanted to talk about, first of all, etiology of pain. What are the different types or phenotypes of pain, and what specifically causes pain in patients with kidney disease? Also, I want to touch base on the prevalence. How common is pain in CKD or end-stage renal disease population? What are the challenges in pain management that we as nephrologists face when we have complaints of pain in patients with kidney disease? What are the different tools, or if there are any tools available specifically for CKD patients or kidney disease patients in general to assess pain? And we're gonna concentrate more on the treatment and the different modalities of pain treatment. And after all, we're gonna highlight what is the WHO, as you all know, the analgesic ladder, and how we can adapt this to be compatible with patients with kidney disease. So first, the classification of pain. When they classified pain, they looked at pain, they classified it into three categories, big categories, whether it's nociceptive, where the pain is coming from somatic and visceral tissue, if there is any trauma or inflammation. The second part is the neuropathic pain, where the pain comes from nerve tissue, whether it's peripheral or central. And when they couldn't classify into either of those groups, they brought it into a different category called the nociplastic, where there was no identifiable nerve or visceral tissue that they could relate pain to. Those are just examples, just brief examples of like what types of pain. So when we talk about, for example, osteoarthritis, our patients who have gout, those are all nociceptive type of pain. Neuropathic pain, our patients who are like diabetic, complaining of diabetic neuropathy. Transplant patients who are immunocompromised and have like post-herpetic neuralgia, those are the neuropathic type of pain. And nociplastic pain is the things that we really don't know: fibromyalgia, IBS, tension type headache, and so on. So our patients that we deal with every day, what causes pain in patients with kidney disease? They have all the causes that any patient can have, or the general population. But on top of that, specific thing, if we look at what we encounter, at least, some pain is related to primary kidney diseases like polycystic kidney disease. Other pains are more of a comorbid conditions like diabetic neuropathy that many of our patients, which is the #1 cause of CKD. Some is because of sequelae of CKD and end-stage renal disease like aciphylaxis. Access issues. Many patients come in, get admitted because of pain, PD peritonitis. That's from a PD standpoint, and just as well, Steele syndrome from hemodialysis patients who come in and complain of pain in the arm where they have the fistula. Renal osteodystrophy is also a very well-known cause of pain in patients with CKD, especially the patients who have like more mineral-borne diseases. And we all the time hear patients complaining of cramps when they are on dialysis. So as you can see, there are many different, and as well some complications from when you have like a TBC or those types of complicated by infection that ends up having osteomyelitis, and the patient is complaining of pain. So different types of pain seen in all our patients with CKD. So we try. So when they try to look at how common is pain in kidney disease patients, in this meta-analysis done at the university in Canada, they looked at 55 publications from 1992 until 2009. And what they have found, they looked at over 7,500 CKD patients and tried to see which patients experience pain. basically most of them, almost 75% of them, were hemodialysis patients. 36 of those studies were only in hemodialysis patients. And this only meta-analysis that I wrote was over 58, so over 50% of our patients complain in a way or another from pain, and almost half of them are complaining from pain as a like moderate to severe pain. So you can see how much effect, like quality of life, is affected in these types of pain. So challenges. I mean, one of the reasons why I wanted to talk about this topic is because of the challenges, and specifically for providers. This paper talked about the challenges of what challenges we can face regarding treatment of pain adequately in kidney disease patients. And as you can see, there are different aspects. One of them is nephrology providers, lack of nephrologist training in pain management, the lack of nephrologist ownership. Usually primary care physicians are the ones who prescribe pain medications. I'm not saying that we as nephrologists need to prescribe all the pain medications, but at least to be aware of how safe each medication is. Unfamiliarity with safety, efficacy, and dialyzability of medications, because many are dialysis patients and they come and ask you, well, is this medication dialyzable? Do I need to redose this medication or not? And hesitancy to prescribe opioids just because of the opioid crisis that's going on. Patient-wise, there are multifactorial etiologies of types of pain. Sometimes different people have different perceptions of pain. Polypharmacy, many people have interactions with pain medications. And system-wise, there is actually lack of quality incentives, care fragmentation, lack of evidence. I couldn't find any specific studies specifically for CKD patients for all types of pain medications studying it really closely. And limited access to non-pharmacological options. I mean, people who go to chiropractor or those types of things are not really covered by the insurance. Tools to assess pain in CKD. Actually, I came across a table. This is a busy table. I'm not here to discuss everything in it, but I just want to mention that there are, in the literature, 8 different assessment tools that most of them are specifically designed for CKD patients. Some of them, as you can see, there are different names. One of them, for example, the Mental Symptom Assessment, Revised Renal, Palliative Care Outcomes, Care Renal, they have different names, and some of them are more of an easy, short ones that can be applied in routine care in the clinic, but others are more for research purposes, where they take around 30 minutes. They ask them multiple questions. Some has more than 20 plus questions. So, for example, just to mention, the physical symptom distress scale, this tool actually was specifically designed for CKD patients, but we don't really apply it much. When we talk about modalities of pain treatment, my topic today is specifically concentrating on the medications, opioids and non-opioids, but I want to mention that there are different modalities, like approaches to pain management. There are main 5 approaches other than the medications, restorative therapies like physical therapy, for example, interventional procedures. People can have like spinal stimulator, behavioral health approaches where they target like with like behavioral therapy, and complementary and integrative like a chiropractor. So I think lastly, this is the WHO analgesic ladder. Actually, this was created back in 1986, and initially it was created as a guideline for the use of drugs in the management of pain, and that was for the general population and specifically for cancer pain. They extrapolated this ladder for non-cancer patients, but the question becomes, can we apply this ladder, which has 3 steps. Step 1 starts with non-opioid that we're gonna talk about, or or like the adjuvants, which also we're gonna talk about, weak opioids, and then go to strong opioids. So we're gonna see how at the end of this lecture, this will adjust to fit our patients with kidney disease. common classes of pain medications. I mean, the ones that I'm going to concentrate on some and touch base on some others. But as we all know, acetaminophen, NSAIDs, anticonvulsants, specifically the GABAergics or gabapentinoids part of them, and some antidepressants are used as pain medications. Most known is amitriptyline. Muscle relaxants also is one of them. Sometimes anxiolytics have been used as pain medication, but not as much. And eventually opioids. I think I'm done with the introduction. So now we're gonna dive into the specific medications. And I wanna start with opioids. Looking at opioids, there are like opiates and opioids. And opiates actually this comes from a plant, the Papaverum somniferum. I practiced this multiple times to say it. I hope I did it right. This is the opium plant from which comes the opiates, and the natural ones are actually morphine, heroin, and codeine. And this is only a subset of group from the big group of opioids, which when they realized the opiates are good pain medications, they started doing synthetic and semi-synthetic ones, which also we're gonna touch base on. All opioids, as we know, I mean, there is some pharmacokinetics. I try to make it as much as possible related to nephrology for us. So as we know, all opioids bind to one or more opioid receptors, whether it's mu, kappa, or delta. They act as complete agonist, pure agonist, partial agonist, or mixed agonist-antagonist. And the mu receptor is the most important for pain control. For us as nephrology providers, what I think is most important is basically to know how, if an opioid is safe or not, is to know the metabolite of the opioids, and specifically two things: whether they are metabolically active, and the second, if they are cleared by the kidneys, or like renally excreted. So I tried to classify the opioids, and I came with what I call traffic light, but it's just the same classification that they use. So as you can see, red means bad. So natural opiates, which we're going to talk about, and the two most common examples, morphine and codeine. Then we move to the semi-synthetic opioids, which include dilaudid that we use a lot, Vicodin. I don't know if we have it here, but we have OxyContin and oxymorphone. And then the green light goes for the fully synthetic opioids, which are methadone, fentanyl, and buprenorphine, which we all know about Suboxone, and most of us know as an opioid use disorder like medication rather than a pain medication. So morphine and codeine, they are both similar actually. So I'm just gonna talk about morphine because codeine will transform into morphine in the body, and it's gonna follow the same metabolism pattern. Those natural opiates are usually avoided in patients. The reason why, as you can see, this is just a simplification of the metabolism. When morphine goes into the cytoplasm of the liver, mainly where it gets metabolized, there is this UDP, UGT, glucuronidase transferase enzyme, which metabolizes the prodrug morphine into many metabolites, but the two most common are M3G and M6G, morphine 3 and morphine 6 glucuronide. And this is where the game is, because the M6G is actually coming out, and then some facts about M6G, which I'm going to concentrate about. It's actually the only active metabolite which has more potent analgesic properties than the parent drug morphine. It does contribute to respiratory depression and neurotoxicity that we fear about when we give patients morphine, especially in renal dysfunction. And it does cross the blood-brain barrier slowly, and I'm going to touch base on the next slide and say why this is important for us as nephrology providers. So what are the relevant facts for us as nephrologists? Morphine and codeine, first of all, dialysability. they have low protein binding and moderate water solubility. And that makes them readily dialyzable. So if we think about it, we can, if someone comes with a morphine intoxication, we can dialyze the patient and get it out. M6G, the metabolite, is also removed by dialysis. However, I said in the previous slide that there is slow diffusion out of the CNS, and that creates what we call a rebound effect after dialysis. So you remove everything from the blood, but then there is some in the CNS that will slowly come back. And this can lead to unpredictable analgesia and sedation. And even if someone gets dialyzed, a few hours after that, you can see signs of toxicity again. This study shows what I was talking about. The clinical significance of the metabolites being the problem was first described in 1986. This is a very small study which took 3 patients with prolonged respiratory depression after treatment with morphine. And respiratory depression persisted for many days after morphine treatment was discontinued. And this actually, if you look at the table, has been shown. They measured at starting from 153 hours up to 400 hours after stopping morphine. And the morphine level was really undetectable in most of them, but the M6G and the M3G were still elevated, and the patients were still complaining of respiratory depression. So that's where the idea of the metabolites being the problem came from. This is the same, which talks about how the morphine is handled elimination-wise in the kidneys. And this actually looks at different patients. They looked at normal volunteers, patients with advanced CKD who are not on dialysis, end-stage people who are on hemodialysis, and transplant patients. As you can see, if you look at this line, which is the morphine line, it's not really that much different in elimination of the prodrug morphine between the different category of patients. However, it's the metabolites M3G and M6G, which, as you can see, last longer in the body and take longer time for metabolism and clearance. Also in transplant, it didn't go back in this study at least to normal, but just to give an idea of the metabolism.
No, in transplant, it did not. Does that simulate the normal?
It didn't simulate, it was better.
Related to their renal function after transplant probably?
Yes, I mean, some of that, it was a small study, it was only like 12 patients. So the transplant patients came back to like normal levels. Some of them retained a higher baseline creatinine, but overall it showed that in the transplant patients, and they were few, they were only, I guess, 2 or 3 of them out of the 12, like the clearance improved, but not back to baseline. So that's what I think is like, just I wanted to bring attention to morphine part, which is as we said, the natural opiate. Now moving into the yellow light, the semi-synthetic opioids, which I'm going to talk about 2 of them, hydromorphone and oxycodone, because we see them a lot in the hospital. So diluted is thought to be better tolerated than morphine. And it's actually metabolized primarily in the liver to conjugates. And the main metabolite, as we said, we care about the metabolites a lot, is H3G. This metabolite is not analgesically active, unlike the metabolites of morphine. It is excreted in the urine, and it accumulates in patients with reduced eGFR. Now, in this study, it was a prospective open-label observational study. It was done in a Canadian university. They looked at 12 anuric hemodialysis patients, and they put them on immediate release hydromorphone. And what they found in the study is that 65% did report reduction in pain using their own assessment tools, but with no clinically significant opioid toxicity. Now, the concern was raised only in case reports that I could find is that we usually know that diluted is safe. However, in some case reports reported that H3G, the metabolite, can have some neurostimulatory effects. For example, those two attached case reports, they suggested that accumulation of H3G may lead to tremors, myoclonus, and delirium. And that's why they were like trying to say that nephrologists should be vigilant for toxic side effects, even with diluted, that we know that it's a little bit safer than more. Now, dialysis implications for diluted. Studies have actually shown, and I attached the study, that plasma levels of hydromorphone decreased by 60% of pre-dialysis levels during hemodialysis. This is actually the same study that they did in the Canadian University. And what they have found when they looked at hemodialysis patients is that hydromorphone did not substantially accumulate, most likely because it was rapidly metabolized to H3G in the liver. However, conversely, H3G accumulated between dialysis treatment, but as we said, it was biologically inactive, so that didn't cause any problems. And that's why the results said no clinically significant opioid toxicity. So another medication that we talk about, like we encounter a lot, is oxycodone. It's within the same yellow traffic light, the semi-synthetic opioids. And oxycodone is actually metabolized by CYP2D6. It's actually metabolized into multiple metabolites, and it is renally excreted. The elimination half-life is lengthened in patients with kidney disease. And what I think we need to know about oxycodone is basically the oxycodone is usually advised to be used very, very cautiously in patients with renal insufficiency. And it does have a large volume of distribution, and it's only 50% protein bound and is water soluble. So theoretically, it is dialysable, but that's based on physical properties. There are no actually pharmacokinetic study done on end-stage renal disease patients so far to test if oxycodone is dialysable and if there are toxic side effects. So because of the lack of the data, it's not really recommended to be used. Now going to the green light, which are somehow medications that are usually restricted in the United States, and most of them are used like methadone and buprenorphine. Those are more used in opioid use disorder. However, methadone, the studies that looked at methadone say that it can be particularly useful for the management of severe chronic pain in patients with advanced CKD. Why? Because it doesn't depend on the kidneys to be excreted. It actually depends on the GI system. It's excreted mainly in the feces, and only 20% is excreted unchanged in the urine. So dialysis patients who are anuric really do not accumulate methadone in their blood because it gets exclusively out through the feces. So these factors do suggest that methadone may be, and I'm not saying that it was studied, but it needs some more study, that it may be a safe, effective analgesic for use in patients with advanced CKD. However, we need to remember that it can prolong QT interval and it needs monitoring for that. Now, how about dialysis implications? Every medication I try to say, like, touch base about how dialysis, because many of our patients are dialysis patients. So this medication is different. And as you can see, the parent drug and metabolites do not seem, it's a flat line, do not seem to be removed substantially by hemodialysis. So if someone is getting theoretically methadone for pain management before or after dialysis, we don't really need to give any supplemental dosages. And that theoretically is explained or attributed to higher lipophilicity of methadone, greater volume of distribution, so it's really in the tissues rather than in the blood, and enhanced or high protein binding capacity. One extra point goes for methadone because it has been found to be more effective in neuropathic pain, which many of our patients have, because it works not only against the mu receptor, but also against NMDA receptor antagonists. So fentanyl is rapidly metabolized in the liver with only 5 to 10% excreted unchanged in the urine, and its metabolites are considered to be inactive. So that's why it's also considered to be safe, and there does not appear to be any clinically significant accumulation of fentanyl when administered to CKD patients. Now, buprenorphine we all know as Suboxone, which is used in opioid use disorder. Actually, what I was able to find is that in Canada, looks like they have been using it for pain management, but in the United States, it's restricted. There are multiple formulations of buprenorphine, not only the Suboxone that we know about. I mean, I don't know, I was new to those, but there are transdermal patches, buccal tablets, which really they state that it does not need a waiver to be prescribed because it's used for pain management rather than for opioid use disorder. However, the Suboxone that we know about needs a waiver, which needs like a specific training to be able to prescribe.
Is it still classified under the opioid category?
Under what you mean?
The opioid category for which you require long-term.
Like you mean Suboxone under the opioid use disorder? Yes.
So if you're having a long-term patches, you still need to have contract and everything.
Yes, because right now in the US, it's used for opioid use disorder. It's not approved to be used for pain management. Yep. So what is good about buprenorphine is that it's a partial agonist, so it has a ceiling effect, which reduces the risk of respiratory sedation, and that's why it's really more likely to be safe. And it does not require any dose adjustments in CKD and is not dialyzed. So it might be a safer alternative to be looked into. Now, the challenges, as we talked about, I mean, many people think and buprenorphine is only used for opioid use disorder, but those are like a study talking about the different barriers behind using buprenorphine as a pain management. And just to mention, like the misunderstanding buprenorphine indications and federal regulations, and the difficulty of monitoring drug use in anuric patients with end stage. So we need more research on that.
So not anyone can prescribe Suboxone.
They have to have a waiver.
Yeah.
Yes.
Like we can do other opioids, but for Suboxone.
Yes, Suboxone can't. You have to have a waiver in the United States to be able.
Probably you cannot prescribe if patients on it, and like when I do internal medicine, I restart the whole medicine.
Yeah, they want
Pharmacy won't restart
No.
until they call the outpatient pharmacy, make sure when was the last dose, what's the QTC.
That's
Then
very-
check the contract,
Yeah.
then only they restart it.
Same thing with methadone.
Yeah.
Yes, those are the two. So I
So if your analysis is that these are safe for kidney failure patients, why are they at the most restrictive level of prescription for general population?
honestly, I don't know if it's more of, I don't know if it's a medical reason or it's a like political or whatever. I don't know, like
No,
what
it's safety reason. actually.
safety reason, like because it has like the addiction, like
So right now, I think it's restricted to addiction medicine.
Yeah.
So you only want to get off the opioid because you don't go in withdrawal, and they have a long QTC property. They give them in lowering doses to prevent the opioid withdrawal, allowing you to slowly come off the opioid
But
with the QTC.
was my question, is the addictive property or the severe
No, I
the
think
strength of action such greater that there may be a negative effect concerns that or
I
like
don't know because
can you quote
Yeah.
it there?
I don't know why the US specifically is not allowing it and it needs like a waiver because as I mentioned, like Canada now is using it as a pain medication, not only as in opioid use disorder. So I don't really know, but I can look it up and get back to you about it.
Because this is obviously the field with the maximum misunderstanding.
Yep. Then comes tramadol. Tramadol is actually, it has dual action. It's somehow classified as a weak opioid, but it is also an SNRI, and that's why it's in a different category on its own. And many people would come and ask you, like, is tramadol okay for me? And what actually turns out that tramadol is not the best drug for CKD patients and advanced CKD patients, because it has it can be metabolized to M1 metabolite. It's not directly nephrotoxic, but the problem with tramadol is its metabolism. It gets metabolized through CYP2D6, and the problem is that you can't predict how much of the drug is metabolized. There are actually poor metabolizers and rapid metabolizers. So they looked at different populations, and in this study, they found out that in, for example, Ethiopia and Saudi Arabia, they are rapid metabolizers. However, in Scandinavians, they appear to have slower metabolism. It doesn't play well with other drugs, and that's another reason why it's not preferred, because, I mean, CKD and stage renal disease patients, I was reading they're like on average on like 15 to 20 pills a day. So there are high risk of interactions with medications. And some of the medications that some of our end-stage people take, for example, cinacalcet, amiodarone. So it's really preferably avoided in
And I think SSRI.
SSRI as well, because it has the serotonin syndrome and risk
The seizure.
of seizures. Yes. So this is part of the opioid. The problem became when there was the opioid crisis. And the CDC, this is from the CDC, and as you can see, when in 2015 almost, there was a surge in the use of opioids, and mostly fentanyl and tramadol. And among patients with end stage, there is emerging increase in the use of opioids in those patient population. So, for example, this is a study, a clinical epidemiological study, which looked at opioid prescription, morbidity, and mortality in the United States dialysis patients. They took the USRDS registry data and the Medicare data. They looked at almost 271,000 patients between 2006 and 2010, and 94% of them were on hemodialysis. They found out that 60% at least received one opioid prescription per year, and at least 20% received it for 3 months or longer, which is like what they call chronic prescription of opioids. And they have found in this study that opioid prescription is more likely in women, in nursing home residents, and in cancer diagnosis patients. And the conclusions of this study is that they found that there is an increasing association with opioid prescription with hospitalization and mortality. Now, similarly, they looked at opioid-related complications. They took out for like 3 complications: altered mental status, patients who are coming with falls, and patients who are coming with fractures. And they used the same registry data, the USRDS. They looked at almost 140,000 people in center hemodialysis patients, all of them. And most of them were like median age 61, men, and were 52% and white 50%. And what they have found is their conclusion was that opioid was associated with adverse outcomes in hemodialysis patients, even with lower doses. So the most common opioids when they looked at different opioids were actually codeine, that we talked is in the red category, and tramadol, which was also in the red category. However, they were still prescribed. So in summary, for opioids, this is my traffic light again. Natural opioids are to be avoided. Semi-synthetic, you want to use them with caution. Hydromorphone, the dilaudid, is more of a safer drug, but I put it in the yellow just because of the fact that there is concern in case reports about H3G, the metabolite in neuroexcitation. And the fully synthetic fentanyl, methadone, and buprenorphine theoretically are more safer for our patients. Now, beloved friend, NSAIDs. So just, I mean, we all know the mechanism, but just because of the sake of the topic, I mean, it acts on the arachidonic acid, COX-1 and COX-2 inhibitor. As we know, the prostaglandins dilate the afferent arterioles, but when you give NSAIDs, it actually prevents those prostaglandins and will cause hemodynamic alterations, including vasoconstriction. This is a similar picture. Basically, this is on the left, you can see the function of the prostaglandins, and when you inhibit them, you actually decrease the GFR. Yeah, it causes sodium and water retention and renal vasoconstriction, eventually with medullary ischemia. Spectrum of NSAID nephrotoxicity. By this time, I think everyone experienced every one of them, or well, not experienced, but saw a patient with one of them. AKI with papillary necrosis, AIM, nephrotic syndrome like minimal change disease or membranous, hyperkalemia, hyponatremia, hypertension, and salt retention leading in edema. And especially patients who are at high risk, like heart failure patients, or patients who are already on RAS inhibitors, or any medication that can affect the hemodynamic status. So selectivity of COX, we know there are different COX inhibitors. Some of them are COX-1 selective, which is like ketorolac, given in the emergency department a lot as a way to save the opioid crisis. And COX-2 is more of like Celebrex and Mobic that we see people prescribed, and those are prescription medication. And over-the-counter like indomethacin, ibuprofen, those are more of the non-selective ones. So the question becomes, are selective COX-2 inhibitors safer than non-selective or COX-1 inhibitors? This study actually was a double-blind, multiple-dose, placebo-controlled parallel group study, which looked at patients with mild renal impairment. So creatinine clearance was around 65. So not a whole lot of like a CKD, but they tried to compare rofecoxib, which is a selective COX-2, with indomethacin. And actually, what they have found is that COX-2 and COX-1 and COX-2 are actually available in the kidneys in constitutive and inducible forms. And this suggests basically, and as you can see, there is no significant difference, and it would have the same effects on renal prostaglandins as non-selective NSAIDs.
On the GI tract, similar, is that the only advantage of COX-2?
Yes, GI, because of the like COX-2 is like present in GI. So for ulcers, basically. Now, do certain NSAIDs cause more harm than others? They tried to look at it, and apparently I came across phenacetin. I don't know if anyone knows about it, but it was the most wanted, and that's what made nephrologists hate NSAIDs, apparently, because of the high rates of papillary necrosis. And it was actually removed from the market in 1983. Now, ketorolac is, and oxycams were actually more likely to cause new CKD than other NSAIDs. And the theory behind that is their long action, duration of action. Oxycams has the longest half-life of all NSAIDs. So the study suggested that, I don't know where the study disappeared, but 2.5 times increased risk of CKD even after short-term use of ketorolac. So maybe that's something that we need to have a talk with the ED physicians. Yes.
Let me interrupt.
Yes.
The next time we're not a non-steroidal, it's a different class of analgesia. Because analgesic nephropathy, not non-steroidal nephropathy.
Okay. Well, I'll double check that.
I really need to check that. It's not I don't think it's non-steroidal.
Okay. Well, thank you for the information. I'll make sure to update everyone on like what I find about it. But my understanding is that it was an NSAID. Good to know. So now with the opioid crisis, people started arguing that can NSAIDs be safer than the opioids that we are doing? And I mean, I'm gonna argue with them, but it's just that they were, in this study at least, they were trying to explore the case for cautious consumption of NSAIDs in chronic kidney disease patients. And they were trying to say that you have to monitor them closely, do PPI prophylaxis, and then repeat BMPs, stop it, use it for the shortest half-life time possible, and mostly in earlier CKD, it should be fine.
I think what it's the way of looking at things at different perspective all over the massive problem with opioid abuse death
Yes, because
versus the very specific concern about a specific organ. So I think these are both valid, but it depends on the argument on what you're looking at.
exactly. This was published after the opioid crisis concerns and everything, so that's why they were trying to say, okay, opioids are still bad, so maybe we need to choose the best of the worst. So topical NSAIDs, I mean, some patients come and ask you like, well, I'm on a like ibuprofen, like gel or cream, NSAID cream or gel. It actually turns out that it's worth a try. There are gels, sprays, and creams. The main concern we have is basically the possibility of systemic absorption. And I actually found this study, which looked at the systemic absorption. I think it's a funny study because they tried to look at topical typical exposure, where they do it on one hand or actually on one knee, and then the maximum exposure, they actually applied it to 2 knees and 2 hands. So they were like trying to give as much as possible, but apparently both of them were flat and didn't really peak. However, this is compared to the oral ibuprofen that or diclofenac sodium that they get. So this is at least one study that I could find. It's a single center randomized 3-way crossover, and basically what it tells us that less likely that there is high systemic absorption in topical NSAIDs. Right. Gabapentins, I'll try to be a little bit faster, but we don't have like lots left. So gabapentinoids, as we all know, many patients are on the 2 most common known are pregabalin, Lyrica, and gabapentin. So how they work is that they act on the alpha-2 delta ligands, and by binding to that, they bind to the L-type voltage-gated calcium channel in the CNS, and they reduce glutamate and thereby reduce transmission of nerve pain signals. Also, gabapentinoids are rising in the prescription. I mean, many patients now they're like on gabapentin. Some people are on hefty doses, like you find like people on like 1,200 3 times a day. So it has been rising. Actually, this shows that almost 65 million prescriptions were prescribed in 2016. And this was just showing pregabalin, which is more expensive than gabapentin, and that's why we don't see it as much, because not everyone afford it. Billions of dollars are being spent on those prescriptions. So how are gabapentinoids cleared, and what we care about? This is, I found this open label parallel group study, which looked at 38 subjects which were enrolled. And the different categories of CKD stage, and they gave them 50 milligrams of pregabalin as 25 milligram capsules. The whole point I want to mention is that they looked at 3 objectives of this study: to determine the single dose pharmacokinetics of pregabalin subject with various degrees of renal function. And as you can see, the bold line is showing normal kidney function, and with the dotted lines, it's more severe kidney function, which basically show that it lasts longer in the system. With dialysis, measure the effect of hemodialysis on plasma levels of pregabalin, and it has been shown that there is a significant amount of dialysability of this medication. So some people might need redosing after dialysis. And this is just showing a linear correlation between the creatinine clearance and the pregabalin clearance, confirming that it's mainly renally clear. This is actually a table I just pulled from UpToDate, which basically compares gabapentin and pregabalin. What we know that it's excreted in the urine almost entirely, gabapentin almost 100%, and 92 to 99% in pregabalin. And hemodialysis, we know that both are dialyzed. However, pregabalin, they expect that it's like 50% dialyzable in 4 hours, rather than maybe if you extend it more, it will be dialyzed more. But more of the gabapentin is dialyzed. And they don't really know if it's possibly dialyzed in peritoneal dialysis. No studies have been done on gabapentin in PD patients, and it's dialyzed in pre-GABA. Side effects of gabapentinoids, which we fear about. I was able to find case reports. Patients who are on hefty doses of gabapentinoids are at increased risk of neurotoxicity, myotoxicity, and AKI from rhabdomyolysis. Those are mainly case reports in the literature that were found. So, for example, that was about gabapentin neurotoxicity in a chronic hemodialysis patient, but this patient was on a hefty dose of gabapentin and acute renal failure due to gabapentin that turned out to be due to rhabdomyolysis. That was attributed to gabapentin. Well, talking about the good part about gabapentinoids, it actually may have a beneficial effect in some common symptoms that our patients have, which are uremic pruritus. So there was some decent evidence supporting their use of uremic pruritus, and in restless leg syndrome, which many of our CKD patients and end-stage renal disease patients. And the conclusion of this double-blind crossover study is that gabapentinoids improve sensory and motor symptoms subjectively in restless leg syndrome patients. So this is just to say that dosing needs to be careful when patients are on gabapentinoids. Start low, increase slowly, and extra caution with when patients are on other psychotropic medication, because there are other interactions with psychotropic medications. So I guess 2 more slides only on antidepressants. The most known is amitriptyline, or the most studied. They are actually well known for their anticholinergic effects that we fear from. And first line, they're usually in neuropathic pain with gabapentinoids. That's in normal kidney function. However, in second, they become second line in patients with advanced CKD, because basically the concern is that it is renally cleared and it's more risk for side effects, including tachyarrhythmias that we hear about in our end-stage renal disease patients. They are unlikely to be dialyzed, whether by HD or PD. And finally, muscle relaxants. The 2 most known are, they're categorized into antispasmodic and cyclobenzapril, and antispastic, which is baclofen. Though this is just an observational cohort study talking about muscle relaxant use among hemodialysis patients. And really, they found that almost 10% of hemodialysis patients are on some sort of muscle relaxant. And they found in the adjusted hazard ratio that there was higher risk in altered mental status, falls, and fractures. Maybe here was the only time in cyclobenzapril that they didn't find a significant relation. And lastly, baclofen. I found a case report about baclofen toxicity in kidney disease. It talks about an altered mental status in a patient with end-stage kidney disease, which was secondary to baclofen toxicity, and that was exacerbated by missed HD. And the whole point from this is that baclofen needs adjustments in dosage, even with the slightest decrease in kidney function. Conclusion, then the WHO ladder that we talked about, this is how they put it in CKD patients. So they try to omit step 2, which has the weak opioids, which are more of the natural opioids and the semi-synthetic. And this table summarizes that in step 1, they recommend acetaminophen, but many patients does not work with them. They still do not recommend NSAIDs. In step 2, they do not use the codeine and the tramadol that we talked about, step 2, to try to avoid. And then step 3, they try to use hydromorphone, fentanyl, methadone, and buprenorphine. They're recommended because they're like the safest so far, and adjuvant, as long as you dose it appropriately, gabapentin and pregabalin are safe enough. However, TCAs are used with caution.